that California, the LA area, had its longest stretch of good air days this past month because people aren't getting in their cars as much.
Amazing.
So that's a silver lining.
Absolutely. So I'm waiting just here, guys, in case you're wondering. Just for a few, it's about 12:02. I'm waiting for people to pop on. We're starting to get people, and I am waiting for our Facebook Live to connect before we start getting into the juicy juicies. If anybody has any questions, please put them in the Q&A so that we can answer them or do our best to answer them. And if anybody just wants to say hi and tell us where you're joining us from, that's always super fun. Please put that in the chat. So questions, please put in the Q&A. It'll be easier to organize it that way. And just hellos and shout outs and where are you kind of thing in the chat. That would be awesome. I might need to let's see what's happening here on the Facebook Live. I'm actually going to stop it and try it to start again because it doesn't seem to be working. Also, you know, if anybody has any thoughts or suggestions in terms of other topics they want to hear about in regards to COVID, that would be helpful information too. Oh, we've got Bev Reed from Kirkland, Washington. Oh, we'll wait to answer your question, Marisa, once we're connected here. I'm going to stop the live stream. I'm going to start again because it wasn't working. I've been out sort of doing a little run around this morning in a social distancing with my mask on kind of way. But
good.
Here we go. Here, this is good because now we're the streaming is coming up. It wasn't.
Okay, perfect. Okay.
I just like to have that going so that our friends, we had a lot of Facebook viewers last week. And so we want to try to get as many people this fantastic, genius information from Karen as possible.
I know a lot of my former students like to come on their phones on Facebook, so they prefer that.
It's cool how we have all these different ways to communicate with people, right?
It is. It's really cool.
Maybe the Facebook, you know, the first time we did this, the Facebook thing wasn't working, and maybe it won't work today either, but. Anna Christine, who's in Kaiser, Oregon, says, it's a beautiful day, lots of flowers and trees blossoming. I'm so grateful that you are here helping us with accurate information. Thank you. Oh, Karen said thank you already. Yeah, you know, I was in a park in Santa Monica earlier, and first of all, there was no one there, and it was filled with water. It's one of the parks that they haven't done like the proper draining system with yet, but because of that, there was just a blanket of flowers that was so beautiful, and like the bees were so happy, and it was beautiful. So nice. Okay, let's see. You know what I'm going to do? I will continue to do this as Karen's talking, but for some reason the live is not happening yet. So what we'll do is I'll work on that as Karen's talking. So if I feel slightly distracted, because I will be the first person to admit that multitasking is not my strength. I know some people think they can do it. I can't. I mean, I can, but I'm not good at it. But I will do it anyway to get us up to Facebook Live the best I can. I'll just keep trying. And so I just want to, and then of course, all of our Facebook people can always view the video will be up on YouTube later as well. So again, just as just a shout out, please, if you have questions, put them in the Q&A. And then if you want to say hello or you have a comment or something, you can put that in the chat and we'll try to monitor both of those things. Karen is I love that Karen has her hat on today. Karen is not a medical doctor. She is a scientist. And so if you have any questions that are medical related in terms of your personal health, please go see a doctor or call 911. Karen's not going to dispense that kind of information. She will give information on the coronavirus as she has for the last 3 weeks in regards to the scientific perspective of the coronavirus. And she spends a ton of time each week educating herself and learning everything new that's happening with the coronavirus as things are changing so rapidly in this world. So give us your questions. Also, this is open to everybody. So please, when you get the links for next week, as long as we're continuing to do this, please share with friends and loved ones if they want to be a part of it, if they want to ask questions. This is for everybody. And I'll let Karen kick it off and sort of give us maybe the state of the union of coronavirus this week. Is that something?
Got ready to do that. Okay. All right. Well, hi, everybody. What I'm doing now, seeing as we'll come to questions soon, but I think a lot of people now have kind of understood, the principles of stay at home, why we're doing it, what's happening out there in general in the COVID-19 world. But I want to try to touch on what's trending now. And one of the things we're hearing and, could possibly prompt some confusion is people are starting to criticize the models and saying, well, did we really have to do all this? And, the models overpredicted certain things. And I just want to, step back a little and give some information with regard to that, because I think the models, honestly, yes, there have been a broad range of predictions. There have been some more extreme predictions. There have been some less extreme predictions. And I will say that the models I have brought forward to show you are the ones I think are most accurate. And in fact, they haven't been that bad. The one the White House is using, the University of Washington model, the IHME site that is funded by Bill Gates's foundation, I actually think they've been doing pretty well. For example, they were predicting for New York that New York would need 23,000 hospital beds, and it's actually at peak, and it's actually 18,000. That's not bad. I mean, given models aren't perfect. Now, the Imperial College models were predicting far more deaths and cases. The McKinsey, the consulting company, they were predicting far more. Now, let me tell you why. One thing about a model is it does evolve as there's more data available, and it should. That's the strength of a model. The more we know, we can start adapting. Now, the original models that the IHME used, and I'll come back. Let me share my screen so we can talk while screen sharing. Okay, I think this is the one I want to use. Share that one. Okay, so let me get out of my email and come over here. Let's see, go here. Let me go here. This is one of the things I want to show. Like, this is New York, okay? So now let's go down. The peak was on April 8th, okay? They were predicting that 23,362 beds would be needed. It's actually closer to 19,000, okay? I don't really know about the ICU beds. Now, let's come down here. This is all resources. This is all beds, ICU beds, okay? And invasive ventilators. I don't really know the numbers. I don't really know the numbers for the ventilators and the ICU beds, but I can say that the all beds needed was a little higher than actual. Now, not terribly. And what were the assumptions in some of the original models? The original models assumed that there wouldn't be very good compliance with stay home and lockdown orders. The original models assumed only 50% compliance, and in reality, it was more like 90%. So that is something that really lowered the actual utilization downwards. A second thing I don't think the models took enough account of is people's loss of income and staying home rather than, you know, going into an ER because either they knew their insurance wasn't good enough, or, you know, they were going to be in a situation of reduced income, and you know, they maybe had a deductible or their insurance didn't cover everything. So I think there were a couple of things that the models don't easily take into account. And that could be why there was a little bit of an over prediction. This model is doing pretty good on death predictions, okay? So that they've actually been fairly accurate on a daily basis. Now, these are the actual numbers, okay? These are actual numbers. If it's before today, you get actual. Going forward, it's projected. And as you can see, deaths in New York are projected to come down so that effectively by May 1st, we're finished here. We've got it under control, okay? Now over here, you know, the utilization, it'll go out a little bit longer than May 1st, but if the projections are correct, by the end of this month, we'll be a lot better off. Now look, it's still pretty bad. There's still a lot of deaths. There's still a lot of need, you know, for hospital resources, but the projections are getting better all the time. Now look here, this is what we call the cumulative death, cumulative deaths. Let's see where we are today. We're at about 7,000, good. It's terrible, but it could have been worse. And now the projected deaths, notice that it's gonna be rising up until about the 1st of May, where you get to the maximum. It's about 13,500. And notice that it's plateaued. It's not changing here. So what this means is it's going to reach its maximum here and not increase. Now notice,
Karen, what are the numbers in parentheses?
Okay, now this is what I was just coming to. Notice how there's an error, there's a range of error, okay? Now notice how we see this yellow color, okay? The 13,500 is a projection. Right now, we've only got about 7,000. So by May 1st, the real number will probably be somewhere between 9,300 and 24,000, okay? Now there's more up here. The error around the projection is not symmetrical. And that's because it's easier to drive things upward if people get too complacent and decide, oh, I can go back to work, I can go out. And this assumes, I want to say one thing about this model. This model assumes social distancing going to June 1st. So what it's saying,
that's an important piece of information.
It's a very important piece of information. What it's saying, we are going to plateau around the start of May. And assuming we keep these restrictions in place, we can pretty much wipe it out by...
And is that June 1st, Karen, for just New York, or is that the whole US?
It's pretty much the whole US. Let's go back. I think today is the peak for the whole US. Let's take a look, okay? Okay, so now the whole US, the peak is today, all right? And where the model is wrong, and we know this, we are not coming up with a bed shortage. There isn't a bed shortage, okay? This number is too high. So the model is off there. Okay, now the deaths per day, we are still, we're at the peak projection, all right? Well, it looks like they haven't actually updated this. Let me just refresh and see if they've updated it for today, because this looks like, yeah, okay, so now we're updated for today. Okay, so yeah, it looks like there's a little bit of lag here in deaths because they have to compile them. So yesterday, there was a projection of about 1,983 deaths. So that's approximately where we are, okay? So on April 9th, there were 1,700. And for the 10th, it's projected to be 1,900. It's about right. So there's been a little bit of a jagged growth. You know, it hasn't been totally smooth, but that's to be expected because things are very different in different municipalities. Now, for the whole US, the 10th, the 9th had 1,768 deaths. That's a fact. That's the actual number. Now, projected for the 10th, it's a little higher, but the range, again, this pink is the range, a low of 500, which is unlikely, and a high of 5,400, equally unlikely, okay? So it's probably going to be right near here. So more likely it'll be around this area here, okay?
Can I ask you a question?
Mm-hmm.
There's been some conversation around deaths not being accurately characterized, and that now you're calling like a lot of things COVID deaths. What are your thoughts on that? Do you think that's really happening, or what have you read about that? Or?
Oh, absolutely. This is just reported COVID deaths, which are probably, it's an underreport, okay?
Oh, it's an underreport.
Yes, I mean, this is what goes into the official register as a COVID death. Now, there could be COVID exacerbated deaths. There can be deaths that elderly people that are not being counted as COVID, where COVID is a factor. So the reality of the deaths are probably a little higher. Again, the same way we are not accurately capturing COVID cases, we're probably not actually capturing COVID deaths. But confirmed cases and confirmed COVID deaths, there is a relationship here, and we're noticing that this model isn't all that bad for it. Now let's go down to total. And I want to be perfectly honest about this model. For most of the time this model has been adjusting, it's been predicting around 81,000 deaths. It's dropped now to 61,500, which to me is fantastic, right? But one thing I have noticed, the highest I've ever seen this model, and it just popped up for a couple of days based on, you know, we had started accelerating testing and they adjust the model. And they also had the assumption of only 50% compliance with social distancing. It had popped up to 93,000. But now I think I'm happy to see that total deaths in the US, now notice this is not like New York. The plateau does not happen by May 1st. The plateau in the country is more like June 1st. Okay?
What are they saying the peak day for the country is?
Let's see. It's today. Okay? So the peak for the whole country is today, but a number of places are not till the end of the month.
And because California was the 26th, I'm wondering, I haven't checked it this week.
Let's see. Let's see what California's doing. We can go to California and have a peek. California's doing pretty well, in fact. Okay, so now California's peak has been adjusted. That's 13
days ahead. That's incredible.
Yep, so the model's adjusting based on the actual data. And now what's interesting is the curve isn't smooth. It's jagged, okay? So that's interesting. But when you do a projection, you just do the average. We'll probably see jaggedness here. So California's peak is coming up. And again, California deaths, you know, when this starts to plateau is obviously a function of when the peak happens, right? So the peak is the 13th. Okay, so here's the
That's
predicted
really
peak.
good news. That's amazing
It is.
news,
It's
right?
great news. And you know what it is? It's a tribute to people being way more compliant than models initially assumed.
So what do
And
you
here,
think that is? That's a kind of a curious thing to me, is that
that
the
people complied.
predictions and the models were that people weren't going to comply. So I guess what I'm curious about is, this isn't necessarily even scientific, this is more like sociology, right? But we can go there.
Sure,
Like
why
the
not?
fact that people are, I wonder what it is, like why is the messaging working? Because that's a
Fear.
pretty bold thing. Is it fear?
I think so. I mean, people see how unpleasant this is, that anybody can be killed, right? COVID, at first we thought, oh, really, the deaths are only in the high risk categories. Well, we know now that's not true at all, that people with no risks in their 30s and 20s are dying too.
Hmm.
So when it became something that could be anybody, and we know very well now that pre-symptomatic and asymptomatic people can be spreading it. Well, I think people saw themselves as more vulnerable than they might have before. So regardless of why, I think the fact that we're revising the models downward is not that modeling is useless and can't help us. I think it's a testament to the fact that although we didn't respond early and we couldn't do the standard, isolate and quarantine that usually works very well, and that worked for South Korea to not need to shut down their economies, that South Korea kept running throughout this because they got on it very quickly. They got on the case very quickly, and they isolated and quarantined, and they had massive testing capability because they got hit very hard with MERS, and they weren't going to let that happen again. So as we start to get down to lower numbers, we can go back to standard epidemiological practice, which is isolate the cases and identify the contacts, inform them quickly, and we can start to reopen the country slowly. Personally, despite the pain, I think it makes sense to continue pretty stringent measures, probably until the end of May. I wouldn't be looking to release things too much on May 1st. Maybe a small amount. We could open small businesses, but here's the risk that I see. If you open it up a little, people are going to push the envelope. And, we say, okay, gatherings of 50, people will be doing 75 and 100, and we'll start to peak back up. I don't think we're far enough out of the woods. Like that, like obviously Washington State might be looking at some relaxation because now their cases have plateaued. New York might start, when they come down and hit May 1st, they might start looking at what can they release, what can they relax a little bit. My fear about relaxation is it'll go too far and people won't respect it. As we start seeing cases dropping, we're going to get complacent, and that will bump us back up because it's still circulating. So I'm actually in favor of keeping more stringent restrictions until June 1st. At the end of May, I think we will be able to relax things. Places that don't have a lot of cases, have a lot of test kits, and good tracing capability, good ability to see a case and find the contacts rapidly. Okay, that those locales could be better off. But our problem in the US, and there's some evidence now that corona was circulating in California even in December from people coming from Wuhan, and we didn't even identify those deaths because we had we had a more serious than usual flu season, and corona looks a heck of a lot like the flu. So there were probably deaths on the West Coast even before there were deaths on the East Coast, because the East Coast picked up the European infected people and they were spreading it before they got ill. So if that's really the case, it's been building a lot longer than we think on the West Coast. So we're starting to see the nature of the spread. We're understanding, you know, how fast it does spread. We might revise our reproductive ratio, which, by the way, that reproductive ratio, the R naught, the number of people you're going to infect if you're infected, that is not an absolute number. It's not a function just of the virus. Yes, partially it's the intrinsic infectivity of the virus, but it's also the public health measures that are in place. It's also cultural practices, you know, how close do people get to each other. Now, the Swedes have got some cultural assumptions, for example, that people of different age groups don't socialize. And they haven't shut down the economy, they haven't shut down schools, but they are they're hit harder than comparable Scandinavian countries around them. So it remains to be seen whether it was safe to keep everything open. I mean, they will pay a price of the health system harder hit and more fatalities. That's an absolute given. Now, could we have made some mistakes? Did we go a little too far and overreact? It's an absolute possibility. I will not say it isn't. In this kind of scenario, because we didn't get on it fast, it's not clear if we could have done, you know, 80% lockdown. It's really unclear. So I definitely think we did the right thing. And only in retrospect will we know whether we could have possibly done less. I think it is still smart that we didn't get to a point of collapsing the health system and that we reduced the number of fatalities. Now, the economic situation can't be ignored. So I really went deep into trying to understand what happened after 1918. Now, the same way that people, the medical community and epidemiologists might have been over predicting. And by the way, there were people, we put a surveillance system into effect after 9/11. There's a very interesting system that was in emergency rooms. Like there's tracking of emergency rooms on an anonymous basis has been going on to try to identify bioterror incidents. Now, sad to say, right before COVID, that system lost its funding because the government figured we don't need it anymore. But the people who developed it were still, you know, using it and still tracking. And there was a public health expert who saw a blip on his system in New York City on March 4th, and he had been eagerly trying to communicate. He started tweeting, he started saying, look, you're gonna get 20 times the COVID cases you've got very soon. And nobody listened to him. New York didn't do shutdown and stay at home until the 22nd. If they had listened to him on the 4th, and started shutting down, we would see nothing like we've seen today. And the reproductive ratio of COVID would be a lot lower there than it is. Okay, we didn't act fast, but as we get the cases lower, then we can start doing more, you know, usual measures of isolation and quarantine, and we'll be able to reopen, you know, the economy. In 1918, most of the effects of the pandemic were very short term. So my prediction is June 1st is enough that the small businesses that have closed down will restart. Now, there'll be some issues. I know I, for one, am not going to feel totally comfortable, doing the kind of things in large groups I used to do, but I will refrequent my gyms. I will refrequent my favorite restaurants. So I will go to my spa and, do my infrared sauna. I will do things with the small businesses. I'll go shopping at Marshall's. I'll go shopping in my local bookstore. So I predict we are going to see a lot of what shut down reopening. It may take a while to reach former levels, but I think the doom and gloom about the economy technically is in recession because so much is not happening. That is true. But I think our ability to rebound is not, my prediction is that it will not be as long as the doom and gloom people are saying. And in fact, I was pumping as much as I could into my 401ks. I was buying stocks I wished I could have afforded before, but I couldn't, and then their price dropped. I'm already realizing a gain on some of that. So although my 401k has dropped dramatically and I'm not thrilled, I predict it will rebound reasonably quickly. So if you're not about to retire, the stock market has been like this, okay? It does take major dips, but the rebounding is relatively quick. So I would say that in 5 years' time, I will be a lot better off financially than I would have if I hadn't, if I didn't have this opportunity to buy things a little bit cheaper. And I've been buying like as much as I can. So that's what I'm thinking based on history, based on the fact that small businesses, many of them are not wiped out yet. There are predictions about even 250,000 people having lost their jobs and never getting them back in China. I don't see that. The factories are coming back online. Delivery service and small business in China is coming back online. So it remains to be seen. I'm happy to admit I was wrong if we see the doom and gloom scenario, but it didn't happen in 1918. It was fairly short term. The economy did rebound. Look, we had some issues, maybe with overexuberance. We had World War I that had just happened, and a decade later we had the crash and the depression, which really wasn't, there's a lot of complex reasons why we had the depression, not all due to margin buying on the stock market. But nonetheless, I think, some of the more, in the same way that the more extreme predictions about deaths and illness were not accurate, I think the more extreme predictions on the economy are also not accurate.
All right. So don't forget, guys, if you have any questions, even questions in relation to what Karen's just saying currently, please put it in the Q&A so we can tee those up. I know I have a few questions too. Let me ask you a few questions, then I'll look to see. I know that Marisa had a question.
Yeah, I see Marisa's question. I see a question about breakdown of death. I can come to all that.
Okay. So, I guess my first question is there an upshot to the not having acted fast in terms of increasing the probability of herd immunity?
Okay, to be honest, and this is a fact, respiratory illnesses like this tend to burn out pretty quickly. When there's a rash, they like, left to our own devices, we would have spiked up like crazy and come down a lot faster. Flattening the curve absolutely draws it out. Now, the reason to draw it out is twofold, as we've said: protecting the healthcare system, including healthcare providers, workers, nurses, docs, respiratory therapists. By flattening the curve, we draw it out way longer, but there's less burden on them, less risk of collapsing hospitals, and fewer fatalities. Okay, absolutely. So, and again, the question becomes, I'm not worried about my 401k. I'm worried about my hairdresser who doesn't have an income. I'm worried about my dance teacher. They just laid off the part-timers at my dance studio. You know, these are the people I'm worried about. The person who runs my infrared sauna is a small business owner who's terrified that she won't be able to make rent next month, and she has a very thriving business normally. These are the people I'm worried about. Luckily, the unemployment benefits, luckily the stimulus, the rescue packages, they're helping. But don't kid yourself. Like the debt burden of these rescue packages is big. And in the US, I wouldn't be surprised if we devalue our currency. We have to print some money maybe. And I'm willing to accept that because I wanted to reduce the fatalities and I wanted to reduce the pain for those who've lost their jobs. Now, I think Republicans and Democrats both, we've had both kinds of administrations. And this administration, everyone since Ronald Reagan has been dismantling the public health infrastructure. I think we've learned that we shouldn't have done that. We can't do it. If in retrospect we see that we've overreacted to COVID, then I think I will forgive the Trump administration because I want to reduce the fatalities. I've taken a 30-ish% income hit myself. Okay, I'll accept that to keep the health system intact, lower the burden on our providers, and lower the number of fatalities. It's already been tragic, and 61,000 deaths is still too many for me. In a short period of time, like this isn't like the whole year. This is within like a 2 or 3 month period. It's awful. So I will forgive them and say, nobody's got perfect information. We tried to make our best decisions, listening to experts and balancing economic loss and loss of life. They did their best. And when all is said and done, we'll see, because we will have another peak. I'm still thinking, because I'm looking at the death rates and stuff in the Southern Hemisphere where it was hot, and they were much lower than in the Northern Hemisphere. And people go to Australia, Australia's got very few deaths. Now they're coming into their fall, so they might see a peak because that's when viruses thrive, when you're indoors, when it's colder. So we're coming into our summer. I believe that will bring us some respite, although I will acknowledge that colleagues are divided on that. I don't say the respite's going to be 100%, but we will expect to see another peak in the cold weather.
Okay, Karen, I don't know if you understood my question. I love the information that you gave us, but I'm going to ask it again.
Maybe I did.
I was like, is she a politician all of a sudden?
No.
She's answering the question. She wants to, not the one I asked, or maybe I didn't ask it.
Okay, well, did I? No, because tell me again what you need to know that I missed, because
I don't think you're like that. I know you well enough.
I could have just
think
missed
you're like that. And it was great information that you gave us. So I'm curious about herd immunity.
Oh, herd immunity. Oh, sorry. Yes.
The relationship to us delaying the stay-at-home orders. Does that help our herd immunity to some extent, though? Because like in New York, you were saying they should have listened to that guy and they should have stayed at home from March 4.
Yeah, potentially.
And they didn't stay home until March 2 or something. So
you were specifically asking of the herd immunity. We would have gotten to herd immunity faster if we hadn't put that in.
Yeah.
So what I'm saying, the stay-at-home orders also delayed the herd immunity generation. Absolutely. You're right. Mm-hmm. But again, flattening the curve also delays herd immunity. But will we get to herd immunity completely? Like, one big wild card here is our asymptomatic carriers. I've heard predictions. How many are there? I've heard anywhere from 36 to 70% of all COVID cases are asymptomatic. Now, Marissa asked, should I get the antibody test? Anybody who can get that test, please get it. Because
Here, I'm going to
that's
show you one
gonna
right
give
here.
us the answer. Okay, now, okay,
This
what
is
are
the
we
test.
seeing?
Okay,
Okay,
so this, I know it's hard to see. Hold on, let me turn this light out here. Let me see if you can see it better if my light is off. Hold on.
and I can tell you a little bit about what that means.
Okay.
Like, there are two types of
So,
antibodies there.
oh yeah, you can see it much better there. See, so this, my son took this test yesterday.
Okay,
I can tell you the name of the manufacturer. So this test, the IgM, which is on my right, on this side of me, that actually tells you if you currently have COVID-19. And then the IgG tells you if you have the antibodies for it, so that you had it previously and now you have antibodies. He tested negative for both. He does not currently have COVID, and he does not have COVID antibodies.
okay, so let me ask how, it looks like you put the blood drop, you prick your finger and
Mm-hmm.
put a blood drop in both of the holes, right?
Yes.
How does that work? Now I see a line at C, like what does the C and T mean?
I think that's the control line. I think that's.
Oh,
so,
got it. Okay, that's the control line.
Yeah. So
So,
it works very similarly to a pregnancy test.
yeah, but how would,
If
like,
anyone's
if
taken
he,
one of those, I have.
okay, okay, now
Um,
what would if he had been, like, if he had developed antibodies to COVID, what would we have seen on that test? Like,
So
what
the,
does a
the T
positive
line,
look?
well, actually, I'll show you. I'll
Okay.
show you because I took all the materials because I knew people would be interested to see this.
Because let me just give you what IgM and IgG mean.
Okay, good, yeah.
IgM are antibodies that are like, we start making antibodies the minute you get infected. The IgM are kind of general. They get a lot of things. You know, they're the first things that'll come up. The IgG are the ones that are the so-called immunological memory. They take longer to develop. They're more specific to the COVID. So let's see what we would have
Do you
seen
see
if
that,
we had
Karen?
I can. Okay, I
It's
got it.
backwards for you, right? Is it backwards?
Right. No, it's fine. No, it's fine. It's actually, for me, it's forwards.
Okay.
So when you have two lines, you're positive. When you have just a line at the control, it's negative. And if you have just a line at the T, it's a failed test.
Yeah.
Perfect. Thank you.
Okay.
That's super
And then
helpful.
here, just so you know, and so basically what happens is cool because I got to see it. My brother administered the test for Adrian. It's pretty cool. I mean, you know, non-professionals theoretically can do it. The instructions are very simple. You prick your finger, and there's an apparatus that you prick the finger with, and you actually pull the serum out with it at the same time. So you take the blood and you put the blood down in those two bottom holes, and then you add the serum to it. The serum also is like a dropper, so you can pull the serum out. You put a few drops of the serum in each of them, kind of just wait. And then it actually says here on the instructions that it takes 15 to 20 minutes. And I think we saw results within less than 5.
Yeah, no, and it
Very,
should
very
be
fast.
that. They
Yeah.
just want you to give it, depending on how fast the blood is diffusing through the the material of the test kit, because everybody's got a different thickness of blood, and that
Yeah.
diffusion can take longer for some and shorter for others. But why it's so important, if you can get that antibody test, this is going to help us determine the number of asymptomatic people.
Yeah.
Like if you're showing up with IgG positive and you had it and you didn't even know it, right? So you were an asymptomatic case. So that's going to help us tell. And the more people that can get this, the better, because this is super important information for the public health people to make a judgment, you know?
Yeah, and if people are curious about this, I'll
Yes,
include this in our follow-up materials too.
people can learn about
But
the
it's
test.
amazing. I mean, it's really pretty extraordinary. Like,
Yeah.
I was like, wow. I'll send also this information. Like, I can't tell you how this test was actually gotten.
Well, I can tell you, but I don't think people want to know. It's very
There's
common.
a phone number here, so you can call them.
Yeah. Oh, I thought you meant how the test worked.
Oh, no, how it was acquired.
Yeah.
So, because I think that's there's a bigger conversation about that, which we don't have to get into today here, but it's like, how do some people access that
Trying to
stuff?
get to the test,
Other
like they're
people
coming.
access it, and there's some inequity with that. So
Yeah,
I
there
get that.
definitely is. There definitely is.
So let's just so you guys know, I have not successfully been able to get onto the Facebook Live, so we're not streaming there. There's a question here from Kwaku Awusu,
Okay.
and Kwaku is asking, what's the current evidence of hydrochloroquine as erythromycin?
Azithromycin.
Is that the
Azithromycin.
myosin, like the antibiotic myosin, right?
Yeah,
And the
yeah.
treatment of COVID patients.
Okay. The trial, the clinical trial that's properly controlled is ongoing. Let me just say there was this tantalizing early evidence that is significant. It's not a panacea. Let me just say that there is, small number of patients, anecdotal evidence, kind of weak trials. The problem with finding out for sure is the trials have been comparing the chloroquine and the azithromycin with other kinds of drugs, okay? Nobody goes untreated in the ICU. Now, it's not been used with moderate cases very much. It's been used with the severe cases because those, particularly the chloroquine, hydroxychloroquine a little less so, there's bad side effects with them and certain people can't take them anyhow. But we have seen that there was protection against death in severe cases, but only, we had groups of 17, and where there were deaths, they were in the control group. So there's some tantalizing evidence that it can be protective in severe cases. It isn't a great thing. There's zero evidence that it's a prophylactic. It's far too intense to use for that. And did it reduce symptoms, and it was a little faster to recovery. So the thing about antivirals, and I've said this before, I'll repeat it because it bears repeating, they're never going to be as good as antibacterials. What we have for flu, the way that works is it reduces your symptoms by 1 day, okay? It can mitigate the illness so you don't get severely ill. Because viruses use our own cells, they use our own bodies to replicate. If you want to attack them, you've got to kill your own cells. So that's usually not a winning combination, right? Viruses like the flu, like COVID, where you have an acute illness and then you recover, antivirals to that have not been great. HIV antivirals are a different story because that's a disease that will take 10 years to kill you. And the lower you can keep the viral loads, the longer you can extend the infected person's life. We don't have antivirals that can cure HIV, except we've seen cures in a couple of fluke cases, but not regularly. We haven't been able to cure HIV patients. So that's the nature of antivirals. They're not perfect, they're not cures, but with acute COVID-19, there's tantalizing evidence, but we haven't done it with enough patients. The trials are ongoing. There are 4 massive trials with the 4 most successful things that we've seen in, we've seen kind of working a little bit. IBM put its supercomputer AI enabled to identify from our whole pharmacopoeia what could work potentially based on what we know about COVID. They've identified 77 compounds. And what's beautiful about this is, this computer power with AI was able to do something in a couple of days that would have taken months, even with standard computing power. So that's a real tribute and a real success story. So,
how accurate are those findings?
They're only candidates, okay? Out of 77, maybe, this is all theoretical. And there's been some kind of interesting theoretical work published about why hydroxychloroquine and chloroquine might work. But I find it, again, it's in vitro, I can cure any viral illness. I can cure cancer in vitro. But it's a very different thing moving from a petri dish to a human body. And there's some interesting evidence of what some proteins, some theoretical bioinformatics on what the SARS coronavirus 2 proteins can do inside a red blood cell, but they can't get into a red blood cell. The red blood cells don't have the receptor they need to internalize. Can sometimes viruses fuse with membranes and internalize? Yes, they can, but it's very, very rare. So the answer is possibly, but the jury is still out on that one. So stay tuned.
I want to go back to Maurice's question because I think we answered it, but I just want to make sure that we did. She said, do you think it's a good idea to take the antibody test? I have a
Absolutely. Absolutely. It's just a pinprick. If you can take it, you will know. If you show a positive on IgG, lucky you. You've had it, you've recovered, and you're one of the herd protecting the rest of us, and you're probably not going to get it again, at least not for a while. So, and it also helps the science. It helps us develop better parameters for models to really know, how many asymptomatic carriers are there. Maybe California has a lot more than it realizes. If it was really there since December, and people who died, we just thought they had a bad flu and we miscategorized that. You guys may be a little bit more protected than some of the rest of the states.
Let me ask you a question because the thought came to me when you were talking about it. If we're looking at the number 61,000 right now in terms of deaths, down from 81,000 and maybe 91,000 at one point, what is the flu death? Because what is the period of time for that 61,000? That's through the end of August.
That's through August 4th.
Yeah.
That's through August 4th.
So what are the starts, and that number would begin in beginning of March, right?
I believe so. I think, yeah, well, it might have gone all the way to February. Let's go back and have a look at the screen. That will tell us where it started.
I'm curious about is what is, and I don't want to diminish what COVID is at all in relationship to the.
Yeah, looks like it started March 1st. March 1st.
Okay.
And these are the predicted deaths between March 1st and August 1st. August 4th.
April, May, June, July. So that's 6 months. So what's the average, like in the flu season, how many people die? I'm just curious from a
okay, kind of an ordinary flu season, 10 to, can be 10 to 12,000.
Okay.
This is quite a bit more than flu. And, epidemic, we sometimes have flu epidemics, pandemic flus. This can be a little higher. But it's usually, with flu deaths, it's usually the elderly and the very young. And we have some years when we don't guess right on the flu shot, some years are lighter. We can have, 6,000. It varies, but I remember, I think it was 2004, where we didn't. How they do the flu vaccines? They actually have to predict a year out. They look at the circulating strains, and then they extrapolate a little bit of mutation and make a judgment about the three. Most flu vaccines have antigens against 3 strains that they put in, an influenza A, B, and C. So they guess what's going to be circulating. And some years they don't guess it exactly right, and the protection is less than what you'd expect. And we had older kids dying in 2004. It was a worse flu year. And, some years we have a better flu year. Some years we have a god-awful bird flu or, H1N1 or swine flu. So again, there's just so many of them out there circulating. And COVID is maybe now going to be just one more of them. The thing to be concerned about is we've got to shut down those wild food markets. Bat eating, bat meat has got to stop. The Chinese government is really trying to work on that. If you want to go out and hunt a bat, cook it yourself and eat it, fine. At least that won't bring it in contact with a lot of people, and there's less potential. If you're a hunter, you shoot one, you grill it outdoors where you shot it, and you probably used a bow and arrow, because if you shot a bat, it would probably disintegrate. But if you caught a bat, cooked it, and ate it, cooking is going to deactivate all these viruses. No coronavirus can survive fire, okay, and high temperatures. So, maybe that could be okay, but we can't be having a lot of bat meat in large markets where a lot of people are coming, they're looking at the meat, they're taking it home. So that has to stop. And we are encroaching on their territory. That's how Ebola got out. This is what happens as humans move into these wild areas. These things have been existing in the forests for a long time. So we really have to rethink our behaviors. We got to shut down wildlife trafficking. What if it did come out of a pangolin? We don't know that that's a fact, but it could have.
Yeah, pretty interesting stuff, right? I mean, there's all kinds of other things that need to be put into place in terms of what animal trafficking looks like and how that happens, certain lobbying and laws and all kinds of things that need to happen to at least protect us further on some level, as we're seeing how impactful this is.
Bats are so important. I mean, there was a terrible epidemic, I think it was called white nose disease, of bats along the Appalachian Trail in the east. It's been a disaster because bats, they do a lot of good things. They eat insects that carry worse diseases for us than most diseases. They help with pollination. I mean, bats are necessary. Agriculture would take a big hit if we lost our bat population. And we lost a huge number to this fungus. It was a fungal disease. The bats got it and it killed them. It wiped out huge bat colonies. And it's still a problem.
So Kwaku has another question. Would you advise people to go with masks when going out? We did talk about this a lot last week, and can that help limit the lockdown period? So just, I'll give you some input from California. This last week in Riverside County, which is east of Los Angeles, they put a mandatory order in by law that everyone that went out had to be masked. And now in Los Angeles, as of, I think it's LA County, as of this coming Wednesday. So that would be the 15th, I think. Oh, tax day in here, April 15th. I'm assuming it's a law or an order that we have to all wear masks. I went out today and there was not a person at the store that did not, or in line for the store that did not have a mask on. Every single person had a mask.
And especially as we relax, like when we go back to work, I'm going to be wearing a mask, okay? Even after they lift some of the restrictions, absolutely. And honestly, right now, the mask is probably doing more to protect others from you, okay? But it does offer a little protection. And I saved this article, like I wanted to show you this thing in the Washington Post, which I thought was great. So are you a medical professional? If you say yes, then you need these high quality masks because you're exposed like crazy. If you're not, do you know how to sew? Well, then sew a cloth mask. They're very sturdy. You can wash them easily. If you can't, well, you can cut out a cloth mask from some old t-shirt or a bandana or something. But I thought this was very, very cool down here where, you know, like there's a couple of things to consider with masking. Now, you're balancing two things. Like you have to be able to breathe through the mask, right? And a lot of people are making them out of vacuum cleaner bags. Now that's a tough thing to breathe through, okay? So it offers very good filtration. The surgical mask is a good balance between you can breathe through it and it's a good filter. It's about 89% blocking. But now let's scroll down. Like vacuum cleaner bags are great for filtration, but they're very hard to breathe through, right?
We were talking about those last week. You were talking about,
yeah. So I never, like I wasn't talking about going whole hog vacuum cleaner bag. I was saying take HEPA filters, okay? But even as I was recommending that, I think I'm going to back off a little bit on that and say if you're really exposed, the HEPA filters are a good idea. Like for the medical professionals, if they can't get the N95s, you can get that HEPA filter in there. But be careful, some HEPA filters, most of them today are made with polypropylene, but some have fiberglass. Some of them aren't made with materials that would be good to inhale. So watch out for that. But some vacuum cleaner bags, you know, it's very hard to breathe through a pure vacuum cleaner bag. I wasn't at all suggesting do that, but get the HEPA filter. But if you're not exposed too badly, like a tea towel, you know, like a little cloth towel that you use in the kitchen, cotton polyester blend, a pillowcase, and the allergen, you know, the kind of things that block allergens. Those are a little bit denser weave. You have linen, silk, a scarf, a cotton t-shirt. They're less good at filtering, but you can also layer them. You can also fold it, you know, fold them over 2 to 3 times, and then you increase the filtration, but at a slight price of breathability. Now, I wanted to also show people a link. Okay, this was so totally cool. I saw this on CNN. And it's like the CNN medical correspondent taking a bandana. You don't have to know a thing about sewing. You fold a bandana and you use hair ties, you know, those things. Let me get them. But you can take a bandana or just a hair tie. Can you guys see me? Are you doing like, yeah, you can see me holding hair ties. This is what I use for my sewn masks. Hair ties and a bandana, you can make a much more comfortable thing. Or just a cotton rag, you know, something you were throwing away because you can't wear it, but you just clean it, you know, fold it over. And it's a lot more comfortable than my hijabs that I'm not too great with, because it holds it in place very nicely. So there's plenty of ways, even if you don't sew a lick, you can.
So your advice to your professional and personal advice to Kwaoku is, wear a mask, right?
Yep.
Kwaoku, where in the world are you? Just out of curiosity, where are you? So, and not even wearing that, like, can that limit lockdown? Yes. And the idea is that, as you were saying, that when you go back to work at USAID, you're going to be wearing your...
Absolutely. I'm going to be wearing a mask out of the house probably in the foreseeable future.
I think that's really, so Kwaku is in Ghana.
Okay.
Karen's second home.
Yeah, that's true.
So, I think it's interesting because I think there was a lot of negative conversation around people wearing masks. Americans really took offense, I think,
Did they really?
often
Yeah, you
people
think?
wearing masks prior to this experience. And I think, wow, this is so interesting to me because I think that people really, were kind of judgy around mask wearing. And usually we would see people that were not Americans wearing masks, and people were like, wow, that's weird. But it was likely people that have lived in places where they have really been affected in a profound way with,
Well,
virus.
I think in Asia, a lot of people wear them for the air pollution, so
Mhm.
that's pretty common there. People who might have asthma, they're not fantastic, but they do block, dust.
Some
They do
filtration.
block. Yeah, they do filter. So there is evidence, and we talked about this last week. There are papers pointing to use it improperly and you're going to give yourself the virus easier. Like if you touch the outside and it's been contaminated, if you keep reusing it and put it on inside out. So just use them carefully, clean them
Yeah.
regularly. And someone was asking, I foresee myself using a mask throughout this calendar year. And again,
So Anna Christine just asked, she said, December 2020?
Yep,
What is
what I'm
is that
thinking.
your foreseeable future is December 2020?
For now,
Yeah.
and I'll reevaluate. I want to see where we stand on vaccines by then, because I also think, well, the public will not get it. The first people getting it obviously will be healthcare providers and highest risk individuals. But I'll see where we stand on the vaccine availability. I will not do gloves. I think gloves is maybe more than needs to be done. But again, hand washing regularly, no touching face. I find gloves are a little hard for me to work in, because I don't use, as we've said, the latex gloves are permeable within 30 minutes, nitrile gloves a little longer. So if you're wearing the same plastic gloves all day, it's bad because you're actually maybe concentrating the stuff on your hands if it gets through. That's not how lab workers and healthcare workers use that style of glove. They change them frequently. So I won't be doing that, but I
I
will
think
be
too with
hand
gloves,
washing.
it's hard to do things with the gloves. Like I've been finding myself
Exactly.
as I'm using them, I'm like taking them on, taking them off. Like I can't get my credit card. I can't. So what I've kind of started doing is try to use some. I've always used towels and stuff to open things up anyway, like bathroom doors and that kind of thing. But it's just really like remember to, like, as soon as I get out of somewhere, I'm washing my hands or using a Clorox wipe on my hands, and then putting some hand sanitizer on my hands, and then washing my hands as soon as I get home. So I'm really focusing on keeping the hands clean as opposed to putting the gloves on, because like I'm a mess when it comes to the gloves. A real mess. It's not pretty.
Yeah, I have a hard time with them too. And again, I think, and this is another thing that we're starting to see more and more. You can get it from surfaces, but it's probably the secondary means. The more common means is contact with infected people, and not just, quickly passing by on the street, but repeated contact, like working in the cubicle beside someone infected, singing in the choir with someone infected. These are it's a more realistic mechanism of transmission. One thing I think I might be doing though, I'll be carrying some of those wipes. I won't be, not Clorox, because I think they're a little too intense, but like I'll probably bring an alcohol wipe. I'll even make my own, like it only, 70% alcohol, just get those, standard tissues or, and like I'll carry one with me. Like when I go into the bathroom at work, I might clean the handle coming and going. Like like be of service to my colleagues. Like if I've just alcohol down the doorknob, if there's anything there, it's gone. You
Yeah.
know, people do that from time to time. We'll keep it off.
Yeah.
So if you touch your face, it won't be a big deal.
I was thinking that in the laundry room in my building, that when I did laundry, I'm trying to do laundry like every 2 weeks to minimize my time in there. But we have 4 washers and 4 dryers, and I completely wiped everything down. And I was like, well, it's good for whoever comes
Right,
after me, right?
you're a good citizen, clean the banisters in your apartment building, and then you might have gloves on. Like I might put on like I have gloves for cleaning my litter box, like Rubbermaid rubber
Yeah.
gloves. Like I might put those on and clean my outside banister, clean my doorknobs, do a little cleaning with gloves.
Mhm.
But when I have the ability, like if I'm in my home, I'll just use a soap and water because that's enough to get rid of the virus. And, believe it or not, there are certain pathogens that have become bleach resistant because we've used it too much to get
Oh,
them,
interesting. And
Isn't it
alcohol
crazy?
probably too, right? Maybe?
Yeah, potentially, yeah. The
Yeah.
way alcohol works in a different way, though. Bleach poisons them, but the way alcohol works, it dehydrates them. Alcohol
Mm.
just when the alcohol is still wet, it's not deactivated. You have to let the alcohol dry, and it literally takes the water out. It destroys the membranes. So alcohol killing is a different mechanism that's harder to develop resistance against than bleach.
Interesting. So Marty asked a question. She said, what if you throw away aftermarket disposable? Marty, I'm not sure what that question is exactly. Can you clarify it? And then she asks, clarify that, and we'll go to your next question. She's asking, how precise are the COVID tests?
Pretty darn good. Like the antibody tests, those are, they're detecting antibodies. Very, very good. There are a lot of false negatives with the PCR, the RT-PCR with the nasal swabs. And that's also not a failure of the test. The tests are insanely sensitive and accurate. But here's the thing. You stuck it up the nose, you do a swab. What if the virus has already gone further down your throat? What if you're not shedding actively now? What if it went right into your lungs and it's not there? So we do know there's a lot of false negatives in the COVID test. We know that.
But I would imagine that like this, now that I've seen this firsthand and how it works, it's this one. For anyone who might not.
Yeah, the antibody test. Yeah, that's great.
It's like a pregnancy test, right? With pregnancy tests,
simple.
because it's picking up the hormone, right? There's very rarely are there false positives. No, false positives. Because if the hormone's not there, it can't be detected, and therefore it's not happening. That's where the pregnancy. Now,
Right, you're not going to have a
might
positive.
be pregnant. You might get a false
but it's
negative.
too soon. You can get a
might not
false
have enough
negative.
of the hormone.
Yeah.
It's the HCG hormone, right?
Yeah.
You might not have enough of that hormone to detect the pregnancy.
Gonadotropin, yeah.
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 So that is like, wow. Now I don't know if this is true. I haven't read it, but I heard this particular test was 99.6% accurate. I don't know if that's true or not. Marty, if you can, and again, if you're here, if you can clarify your question,
if you mean like you only have your gloves on for going shopping, yeah, could that be it?
Maybe.
If you don't have the gloves on long, the whole idea about those gloves is they're permeable. Nothing is impermeable. There are some super heavy duty fancy gloves that, really can block things for hours. But these are like people working with serious poisons and stuff. But yeah, now the antibody tests, they're out there. They're getting out in the system. You can make an appointment with your doctor to get one. I don't know if they're going to make it to the point where you can buy them in stores and just do it at home. I don't know. They're easy enough to do. They're very similar, like malaria tests are like that. And individuals in, the malaria endemic areas, they're called rapid diagnostic tests. You can buy them in pharmacies. Maybe they'll do that.
How long have those been out? Because I know when I was spending a lot of time in Africa, that did not exist.
It
And it
didn't. I
was
mean,
like
that's a more recent thing.
my,
Yeah.
often I worked in, most of my time I spent in northern Kenya. And it was so funny because anytime, not funny, but anytime anyone was sick, they called it malaria. And I'm like, are you sure about that? And it
Right.
was kind of like malaria had become like a blanket term. So how cool.
Exactly.
Now, maybe the people that I worked with, those tests would not be accessible to them anyway, because I'm sure they cost money. But
Yeah, I mean,
um,
they're not bad. I mean, they're getting cheaper all the time. But yeah, if you can't even afford a test, the way they used to do it is they would take a drop of blood. They would look for the parasite in the blood. There's a staining protocol. And, it can be done pretty quickly nowadays. Just take a drop of blood, put it on a microscope slide, a few chemical reagents to stain the parasite and fix the slide, put it under the scope and have someone look at it. Yes, it does depend a little bit on the skill of knowing what you're looking for.
right.
Finding the ring stage of the parasite in the red blood cell. But these things are even faster, like the kits, what they call the RDTs, the rapid diagnostic test. You put the blood in, and like the line appears in 2 minutes, right? And yeah, but that might cost you $1, right? And some of these people can't afford that, whereas the smear might cost you 10 cents. And
Mm.
if you can't even pay for that, it's always a presumptive diagnosis. And what's interesting is how many early COVID deaths or early COVID cases looked like the flu, and the doc said, oh, go home, fluids, Tylenol if you need it. We missed a lot. We missed them.
Yeah.
And,
But there was no testing, so it isn't
there you go.
possible
We
to
couldn't
know.
have done any
So
tests, but if
Marty
you can get it.
clarified. She said, "Oh, disposable gloves for marketing. Oh, then toss in the trash." So what if you just use those, the
Oh, yeah, if
plastic
you just
gloves?
go
And
out, like if you only use them like a half an hour, yeah, then you're
because you're
okay.
saying 30 minutes really is what you got, right?
Right, for the latex,
Yeah, for latex
stuff.
gloves. And
The
Marty's
others
actually
are
a
longer.
hairdresser, so that's probably what she has access to, are those latex gloves, because she uses
And
them.
the vinyl gloves are longer, the nitrile gloves, the blue and purple gloves, they give
Okay.
you longer protection. I'm
How much
just
longer do
saying,
you have on
don't do it
those?
all day. Couple hours, I think.
Hmm.
It's just, all I want to say is it doesn't last all day.
Yeah.
If you got something on your glove at 9 a.m. and you still have the same gloves on at noon, no matter what type you have, it's gotten through by
Yeah, don't
now.
make the assumption that you're cool because you got the gloves on.
Exactly.
That's the
That's all.
headline.
That's
Okay.
all. Yeah.
So, oh, thanks, Marty. She said I'm a great host and conversationalist.
Oh, that's
Does
nice.
that
Yeah,
surprise you?
you are. You're very
Can
good.
talk.
Yeah. Well, you do
Um,
this for a living.
yeah, I ask people questions for a living.
You're a
Yes,
coach.
exactly. So, and then she asked, did you ask how accurate Guyer's test was? I hadn't read this, but I heard, he told me, so I don't know where he's getting his information. He told me that it was 99.6% accurate. But Karen, have you read about any of the, about
There are different tests. I
percentages?
don't know which one this is. This style of test tends to be pretty good. Okay. And we have them for a lot of other things too, not just COVID. Okay. This style of testing is kind of like how we do things for a lot of other infections and so forth. So they tend to be good. Can there be false negatives? Yeah. Can there be false positives? Yeah. But again, not the false positives tend to be far less common, because if it's there, it's there. You've had it. But a false negative, maybe if the antibody titer is too low, it might not show up. That is a more common thing with this type of thing. But honestly, it's not the kind of things that get out into the public, because we've been doing this for so many years now. We know how to make these things, and we know how to make them specific and sensitive, which are the two things any test has to be. It has to be specific to the pathogen you're looking for, and it has to be sensitive. So if it's low dose, if it's low level of what you're looking for, you still want to pick it up. Nothing can go down to almost 2 copies, right? I mean, there's a sensitivity cutoff for anything, for any type of thing. So if it's super, super, super low dose, you probably don't have protection with that lower dose anyhow. So you might as well be negative.
I have a question for you, Karen, about like antibody level. So is there value in having more antibodies? And obviously these tests are, it's so funny because I go back to the pregnancy test, which keeps reminding me of, you can be kind of pregnant, like you either are
right. I mean, that's
not.
the thing. It doesn't matter.
Like, so does that, from a scientific perspective, like, is there value in knowing how much antibody you have? Like, you might not, if you get a little bit and test positive for it, but that might not help. How does that work? Or does it work?
Oh yeah, there's absolutely more protection in a higher titer. And there are more sophisticated and expensive ways to tell you your titer. But seeing as we don't know what a protective titer is, very likely, I mean, these are not so detecting so low because the sensitivity has a cutoff. What you're seeing on that test is probably a protective titer, but we don't know. I mean,
Right.
we just had, this is too new. We haven't done the studies yet, but I would assume knowing where you have to be to test positive with most of these antibody tests, I would say it is protective, at least for a period of time. We don't know how long it takes to lose the memory with COVID-19.
So Marty asked a couple. I love it. Marty's asking more questions. She asked last week. I love our curious fans out there. So Marty's saying, how many variations of COVID-19 are there? And then are the variations like general to severe? Like, do you think that the different strains, some are harsher than others? And I don't know if there's anything about that yet.
Well, at last count, I saw 103. And there are two major groupings, the S and the L. The S is thought to be the parental strain, and the L was descended from that. But we talked about this on my Marco Polo. Viruses exist in what we call a quasi-species, okay? What that means is, if you're a biologist or took high school biology, you know that DNA has 4 bases, right? RNA has 4 bases, just one is different. So now let's pretend COVID is a single-stranded RNA genome. So let's just pretend, we're looking at its base sequences. It goes base, 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 base. Now, what a quasi-species is there are mistakes at all of these positions, right? So there's an average genome, which means base 1 is this, base 2 is this, base 3 is this. But there are mistakes, okay? And some of those mistakes aren't lethal. The virus can still replicate. But at every position, there is a certain amount of mistake. And when we say that there are 103 strains, this alphabet for the viral genome is different, okay? But yet they all exist together. Now, if a selection pressure happens, okay, and that is a drug treatment that preferentially kills certain of them more than others, then they kind of go down in the population and the relative representation of others rises, which is why it's hard to wipe any pathogen out, because they don't exist as one single entity that you can target and kill. It's like the human population. We are basically got human DNA, but every single position is different. They give you different height, different eye color, all kinds of different things. And if we were one single thing, we could get wiped out easier. And this is believed to be part of the problem with the Native American populations. They were descended from a small group of founders, so their genetics are much more similar. They're more closely related. So when a disease for example, smallpox, when smallpox got to North America, it ravaged them because they didn't have a lot of variation in their, immune systems. Okay? They were kind of similar. And a lot of them, and it was, and particularly they had a susceptible, immune background there, and they got wiped out. The more genetically variable a population is, the more it can withstand a hit because everybody's different.
You look at that, I mean, there's conversation around that with like dogs and breeding, right?
Oh,
the dogs
same
that have
thing.
the purebred dogs have a lot of health challenges, and it's the mutts that survive all kinds of crazy things.
Exactly.
It's an interesting conversation around people that are biracial, multiracial.
Oh yeah, the biracial, multiracial people,
Yeah.
boy, they got an advantage. They've got advantages.
So that makes me feel good as a child of a biracial child. That
hybrid
makes me feel
vigor,
awesome.
they call it.
Yeah, that's pretty cool. So Marty has more questions. Low grade COVID. Can it keep coming back? Okay. If meat markets closed in China, will all the viruses stop forming and birthing? If this type of animal if this is the type of animal markets that's causing the world pandemic?
Well, we hope it'll slow it down at least. What we know, there are so many more coronaviruses in bats. Is this the worst of the lot? Look what we've seen, because we're encroaching on their environment and bringing them to us. Look what we've seen. First SARS, then a few years later MERS, then a few years later COVID-19. What's next, right? So if we shut down the wild meat markets, not domesticated meat markets, because we monitor the health of beef and chickens, they've changed how they sell chickens. Like in the Asian markets, they tend to sell live chickens, and that's what was causing the problem with bird flu. And particularly, they used to stack the cages on each other, and the feces from the top cages would drop down to the bottom cages, infecting all the birds. If you had a bird with flu on the top, it would infect everybody below that. Now they've stopped that kind of process. They keep them all on a level, they vaccinate them more. But the reality is, aquatic waterfowl are what are the reservoir for flu. So a wild duck, we can never get rid of it because it's out there. We can't vaccinate wild ducks. COVID, luckily, is a slow mutator, and that's good that we can probably raise a single vaccine against it. Bill Gates is funding 4 promising vaccine candidates, and he's also building the production facilities for each one. And that's a big thing because,
awesome.
Hey, say we got a great one, making enough of it. It's the challenge is producing it and getting those doses out for a population of over 7 million in the world, right? So he's building 4 factories.
7 billion, right? 8 billion.
Something like that. I thought it was 10. Hey, it's a drop in the bucket for him. It's the least he can do.
Wonderful. I think that's so cool.
7.7 billion human beings.
Yeah. But it's so amazing that, people like him, can use the money they had truly for a force for good. Like it just.
Right. I mean, he always said that. He said years ago that he wasn't going to destroy his children by letting them inherit all his money. He said he would give it away, and he's been true to his word. And the very first thing the Gates Foundation did years ago was try to help developing countries purchase vaccines.
Yeah.
And he's still a big part of the Gavi Alliance, which does that to this day. So he's stuck with that, and his foundation has expanded as he's seen other needs and other issues. So I give him credit for that. He's also been big on education in the US, particularly science education.
Mm-hmm.
So there was plenty I didn't like about how we did business, but this is the American way. You're an obnoxious business person, and you become a philanthropist towards the end of your life and redeem your legacy. Andrew Carnegie started it. He was god-awful as a business person, was known for shooting striking workers, But he started Carnegie Mellon University and
In
libraries.
my
And
hometown.
so, I mean,
You know,
you have to
Pittsburgh was
balance
the home of
both
philanthropy. I mean, philanthropy started in Pittsburgh at the turn of the last century.
absolutely, because that's
So
where he worked, right? That's where he
yes,
had his
and
factory.
him and a lot of other big magnates. That was where the money was at the time, was in Pittsburgh.
Yeah.
So yes, we do see that, and hopefully there's a shift in paradigm happening where people are creating businesses that are more have more integrity, are more aligned with society, and then
Well, let's hope that that goes away, that people do business better, that you don't need to redeem yourself,
yeah.
you.
So any more questions? Because we are at 1:33 in Pacific time. I guess it's Pacific Daylight Time now. Is it daylight?
Yeah, it's daylight time. It's
Yeah,
daylight time.
PDT, Pacific Daylight Time. And I want to be mindful of everybody's time. We will come back. Today's Saturday. We did Saturday instead of Sunday this week because of the Easter holiday, which is something that I celebrate. And so we'll be back. I think we'll go back to Sunday next week.
Yeah,
Sunday
that's a
seemed like
good
a good
idea.
day. So we'll go back to Sunday next week, and please share with your friends, anyone that might be interested. I was not able to successfully get us onto Facebook Live today, so that just
Oh, yeah, we
happens.
forgot one thing about the stats. I'm sorry. We forgot one question.
Okay, go ahead.
Like the death rates for the different groups. What's also interesting, it's very different from country to country. In China, it was about 3.4%, Korea 0.7%. And part of this is how good is the treatment and how quickly are you getting treated. The rough estimates are the people in the risk group, the fatality rate can be as high as 10 to 20%. And the no prior lung or heart conditions, no problems whatsoever, around 0.3. But it's really dependent. We're compiling this on the fly as we go.
And what does it look like, Karen, in the US? Do we have numbers on that yet?
It's very different place to place, okay? In the US, we're looking at it by risk group, and it is, 10 to 20%. There are issues, as you've heard, minority communities, which tend to perhaps, well, our African American community has higher diabetes, higher high blood pressure. High blood pressure is a really bad risk factor because most of those people are on angiotensin, ACE inhibitors. So they tend to have a much richer, they have a lot more receptors for the virus on their cell surfaces. So, there are certain things, poor nutrition is also a risk factor. A new risk factor is living in a bad air, getting a lot of air, breathing a lot of air pollution.
It's happening in many places right now.
So it's very difficult, but we're finding a death rate in some of the minority communities that's double in the majority communities and the wealthier communities. So the stats, the jury's still out. They're not all in. But we know for a fact the vulnerable populations, elderly, lung and heart problems, 10 to 20% fatal. And if you get on a ventilator, only 50% of people get off a ventilator alive or live once they're taken off. So, and those who even live have pretty severely reduced lung capacity, and we don't know for how long, okay? We're hearing reports, people in their 30s and 40s who need ventilation because they were asthmatic or had lung issues. They were in a vulnerable population, they survived, and they can't walk across the street without getting winded. Their vocal cords are damaged from the intubation. And we don't know, maybe in 6 months they'll be fine, but they're not coming off ventilators totally okay. They're coming off with some reduced lung capacity. So,
Marisa, I'm curious, just before we close out here, are those the stats that you were looking for? certainly interesting stats. I'm just curious, when you said stats, is that what you were looking for? And if there's something else, please let us know before we.
Yeah, that's what I thought you meant, like who dies from it. And we know everybody can die from it, so nobody's safe. But realistically, young people with no prior conditions, non-obese, not, well under 1%, well under 0.5%. But again, you don't know if you're that unlucky person that mounts the super strong cytokine storm immune response.
Mm-hmm. And also, you don't know if you might have some sort of underlying condition that you just weren't
exactly
aware of.
Right. That's the whole thing. People are discovering they've got underlying conditions when they show up severely ill.
Yeah. Well, Karen, thank you.
And happy Easter to you.
Thank you.
Have a wonderful Easter.
And happy Passover to our friends that are celebrating Passover. It's really been what other holidays are happening right now?
Yeah.
Is there a Muslim holiday?
Happy belated Passover to those who celebrated last Thursday, and happy Easter and happy Sunday, whatever, or happy whatever you do on Sunday.
So we'll be back next Sunday at noon Pacific time, 3 Eastern time. Please share with friends. I will try to get it out on Facebook. I'll send you guys a follow-up with some links. I don't know if certainly we can show you. We'll share this stuff too. We'll share the test.
Yeah, that's very cool. And get it onto YouTube, because I'm telling people, Google YouTube if you missed the previous ones. But we'll keep doing this as long as we have an audience that has questions they want to answer.
Perfect.
Right, Kristen?
Yeah, I'm in. I'm all in. All right.
Okay.
Sending love to all of you. Okay.
Okay. Bye-bye, everybody.
Weekend. Bye.